A continuación, la doctora Viviane Nasr. Ella nos va a dar el tema de valoración del riesgo en el niño para predecir mortalidad perioperatoria. La doctora Nasr es profesora asociada de Anestesia Perioperatoria del Hospital Pediátrico de Boston. También pertenece al Departamento de Cuidado Crítico y Dolor y es una profesora asociada del Departamento de Anestesiología de la Universidad de Harvard. Bienvenida, doctora. En esta conferencia tendremos traducción simultánea en la parte inferior de sus pantallas. En la plataforma de Zoom abrirán el icono de interpretación y activar el idioma que quieren escuchar este interesante tema. Bienvenida, doctora. Muchas gracias.
Thank you for the nice introduction. Thank you for the organizing committee for having me join you in this great meeting today. I'm going to share my screen now. Can you please confirm that you can see my screen? Can you see my screen so I can start?
Yes, we can see it.
Okay. Okay, sorry, I couldn't see the message. Thank you. So I'll be talking about perioperative mortality risk in children. As you know, pediatric cardiac care have evolved between surgery and medical treatment. So the number of patients presenting to us, whether cardiac, non-cardiac, or any in children in general, have increased. And with that increase, they present for us for non-cardiac procedures more often. And so what is the risk of those patients when they present to us is important. So the objective of today is really discuss the risk factors of major perioperative adverse events in children and to understand the most recent risk scores of mortality in children presenting for non-cardiac procedures. What is a risk? And so when I say risk, we have to think about it as a measure of probability. It's a statistical chance of an occurrence. Usually when we say risk, it's the occurrence of something that is undesirable. And it is something that happens to us every day in the perioperative arena. Whenever we have a patient, we think about, is this patient going to be awakened at the end? If this patient has the risk of remaining intubated. So we weigh the risk versus benefit of every procedure, of every drug we're going to give. And the risk depends on who's looking at it. As an anesthesiologist, maybe we think about the risk of extubation at the end, the risk of having hypotension. However, as a healthcare provider or hospital management or insurance company, they think about other risks, the risk of this patient staying too long in the hospital. Hospital management think about the risk of losing patients and patient satisfaction. So it depends on what risk. And so it's important when we think about risk is to understand what is the definition of the risk that we're looking into? How do we measure it? How do we quantify it? And therefore, after deciding on those, then you can decide how do we assess it. So when I think about risk, I think about it in terms of 5 Ds, and risk of death, mortality, risk of disease, discomfort for the patient, disability, dissatisfaction, and depending on the healthcare system that you're in, it could be the risk of dollars and cost for the patient. And the risk exists throughout the perioperative process. Preoperatively, when we're evaluating a patient, we think about the risk and the risk of having any diagnostic procedure that might be needed. In the OR, we think about the risk of the procedure, of the induction, of any anesthetic drugs that we might give, monitoring, or the operating room itself, what are we doing to the patient? And then post-operatively, we think about the discharge or a continuous mechanical ventilation, mortality, morbidity, or any hemodynamic. And so when we think about all this, we think about them as adverse events. And so how do we really keep track of these adverse events that could happen throughout the perioperative process? And certain institutions have mortality and morbidity sessions where they keep track of these adverse events. But really, to think about the adverse event and think about risk factors, we have to have a collective effort to look into this. And one of the initiatives in the United States have been the Wake Up Safe. It's a quality improvement initiative. It's a registry that collects serious adverse event in pediatric anesthesia. It is supported by the Society of Pediatric Anesthesia. Around 34 major institutions participate, and the caseload per year is around 500,000 anesthetic. Another registry is the Pediatric Perioperative Cardiac Arrest Registry, and they have looked as well at risk factors for patients to have cardiac arrest, and they have been patients that are younger in age, infants, ASA 3 to 5, and patients who are having emergency procedures. So these are commonly known initiatives, but we also have a lot of literature on this that have looked into what are the complications related to anesthetics. And you can see here from the dates, it's been a topic that is ongoing from the 1980s, 1990, 2001, 2004, trying to look at what are the risk factors for adverse events. And we always have infants, young age, but we also have the ASA here. So if I have an infant and I have an ASA 3 or 5, then I'm concerned. But really, what other than concern do I get? What is the objective measure of this? So when I look at all what have been done so far, we can identify risk factor for cardiac arrest in any patient with this ASA, age, and emergency. We can think that infants suffer respiratory complications more so than cardiac events, unlike in adults. And post-op vomiting is common in older children. However, as you all know, the ASA might be very subjective. So really, the only objective measurement is the age, less than 1 year, and emergency procedure. So we need a little bit more than that to really help determine the risk of those patients. This is a European study that is recent, and the S.A.R.V.A.C study, and it looked at critical events in pediatric anesthesia. It's a prospective multi-center study in 261 hospitals in Europe, and they have looked at 33 European countries. The adverse events they looked at are respiratory, cardiac, allergic, or neurologic, and the incidence of these events was 5.2%. What they have seen is that the incidence of severe critical events in children really happens in less than 6 years. So earlier, when we looked at the events, it was mostly focused on cardiac, and it was infants with cardiovascular events. But when you look at all the events, including respiratory and others, there are children less than 6 years. Medical history was important. Comorbidities that the patient have is important. And again, they mentioned the ASA. I'm going to discuss a little bit the ASA here. I'm sure for all of you anesthesiologists on the call, you know what the ASA is. And this was developed in 1941. It was a task given by the American Society of Anesthesiologists to devise a method with which we could collect and tabulate outcome from anesthesia. They developed 6 classes of physical status. As you know, normally healthy, patient with mild systemic disease is class 2, class 3 severe, class 4 is incapacitating, class 5 is moribund. And it was adopted by the American Society of Anesthesiologists to try to assess the physical status of the patients prior to an anesthetic. The ASA helps us describe this preoperative status, but however, it was never devised or done to be a predictor of perioperative outcome. Even though it comes up as a risk factor in many of those registries, it was never designed to be a predictor, and it was never really validated as such. In fact, most of the studies that look at ASA show that there is an inter-rater reliability and variability. So we kind of need a better tool to really assess the anesthetic risk for those patients. This is the ASA physical status in pediatric practice. And so even in pediatric, this is a study in Australia looking at 15 hypothetical scenarios. And they have shown that 55% of the variance in the ASA physical status grading was due to measurement error in the ASA itself. And for pediatric, it's important because the ASA does not account for congenital malformations, it does not account for syndromes, and it does not account for the developmental stages and milestones in pediatric patients. In fact, this is by colleagues at Boston Children's. They have looked at 4,564 patients that were admitted as inpatients postoperatively. And they wanted to look at the ASA status and the number of chronic conditions in those patients. What they have shown is that, as you know, ASA1 would be a patient who has healthy, so should not have any condition really. But 45% of those patients actually has a condition and were listed as ASA1. ASA2 is split between yes and no, and ASA4, they have no chronic conditions and they are 100% really patients with chronic condition. So in patients with 2 or 1 or 3, there is still variability in how we assess the patient based on the ASA. It has been used for billing coding, for insurance purposes. However, it's really not the best tool as of now. A more recent study by that same group have proposed the pediatric ASA scoring, and currently ongoing studies are trying to assess if this pediatric ASA it would be a better tool. And so there is more to come, I guess, in the next few years on that topic. But meanwhile, now we know that the ASA is not the best tool. And we have to think about the patient when they come to us as the patient, what type of procedure they're doing and where they're getting this procedure done. So let's start with the patient's condition. And I'm going to focus on mortality as mentioned in the title of that talk. So the pediatric risk assessment score is a score that we have devised to look at mortality incidence and what are risk factors of mortality. As you know, mortality is a rare event, but when it happens, it could be devastating to the family, to the patient, and to us as providers taking care of those patients. The ACS NASWEB database is a national surgical quality improvement database that collects all this information. And so we have used the data set in 2012 and 2013 to look at the incidence and develop a model that would allow us to predict the mortality. And we used the 2014 cohort at that time to validate it. What we have shown is that the incidence of mortality was 0.5% in the derivation cohort and 0.4% in the validation. And the factors that are used in the multivariate logistic regression to predict post-op mortality were multiple, including hematologic disorder, pre-op transfusion, congenital heart disease, age, again, less than 12 months, mechanical ventilation, or neoplasm. When you look at the PRAM score, what we have called it as a shorter terminology, we have 5 variables. So if the procedure is urgent, it's a +1. If you have a comorbidity from respiratory disease, congenital disease, kidney, neurologic, hematologic, it's a +2. Critically ill is a +3. Age less than 12 months is a +3, and neoplasm is a +4. And what you can see here is as your score increases for the PRAM, your mortality rate increases. So patients with 0 on that score have 0 mortality. But if you are above 9, your mortality risk is really high. And when we compared the PRAM to the ASA distribution, you can see here the variability with the ASA. And so ASA above 4 for certain patients with a PRAM of 0. And this variability, the histogram really just goes along with what I've been mentioning earlier about the variability in ASA rating. However, this was using a national surgical quality and patient database that includes academic, community hospitals, and we wanted to look at it within our hospital and see if we can do external validation. So we took a total of 13,500 surgical cases at the hospital. We had implemented the PRAM in the medical record, so there was no missing PRAM data. Every patient that came during that year had a PRAM collected, and the incidence of mortality at our center was 0.21%. And you can see here that the model really area under the curve was 0.95, proving an external validation that the PRAM actually can predict your mortality perioperatively. And even internally at our institution, we could see also the same variability between the PRAM and the ASA. In that external validation, we noticed that the PRAM scores above 6 and less than 3 were really a perfect determination of mortality. The patients with the incidence of mortality with an ASA less than 3 increased risk of 8-fold. So if you have an ASA less than 3, you could see the variation. But then for those who are less than 3 with a PRAM score above 6, you have an 8-fold increase in mortality. So the PRAM was able to be a better determinant. Now, we are not the only innovative people. You can see here the pediatric surgical risk calculator that was developed by the ACS-NASQUIB to try and really quantify not just the risk of mortality, but also other outcomes for post-operatively, such as pneumonia, cardiac complications, surgical site infection. The difficulty with that tool is that I couldn't find in the literature any explanation on how this tool was developed or how it was validated. And hence, more research is needed to really understand how to determine these risk factors using that tool. Now that I described you the patient's condition in terms of preoperative variables that helps us, let's look at the surgical procedure. So if a patient with the same condition is coming to us for a knee arthroscopy versus coming for a spine fusion, is there really a difference in outcome? And how does this intra-op surgical procedure play a role? Using the same database, the NASQUIB, we have looked at the derivation and the validation cohort. CPT codes means current procedural terminology, and these are surgical procedures. There were 659 surgical procedures included, and among these cases, the mortality rate, 30-day mortality, is 0.34%. What we have seen is that when you have this certain number of comorbidities, if you take a patient with 4 or 5 year comorbidities and undergoing a low surgical risk procedure, the risk of mortality is 4.7%. That same patient undergoing a high risk surgical procedure will have a 46.7% risk of mortality. So the procedure itself plays a role in the risk of mortality, not only the preoperative factors. To really explain what's the intrinsic surgical risk is that the 30-day mortality rate or probability have been divided into 4 risk quartiles. Risk quartile 1 is 0%. Risk quartile 2 is between 0 and 0.14%. And you can see here the 3 and the 4 is above 1.15%. To put it a little bit in perspective, I listed here a few examples. So patient with surgical procedure with risk quartile 1 would be arthroscopy, ear procedures. Risk quartile 2 would be appendectomy, hip osteotomy. Risk quartile 4 would be examples such as burr hole and hepatectomy. So patient's condition play a role, surgical procedures play a role, and this is all related to mortality. How does a provider and hospital play a role is still a question that remains to be answered. However, as I mentioned earlier, is that the risk of mortality is low. And so many of you are wondering or are more interested in understanding what's the risk of morbidity. What is the risk of my patient needing ventilation postoperatively? What is the risk of my patient needing an intensive care unit bed after? So when we wanted to look at that, and we used only our institutional data to try to come up with a risk assessment of morbidity in pediatric patients that we abbreviated as S.A.R.V.A.C score. And we used a derivation data set and a validation data set. 9% of the patients experienced a composite morbidity outcome. And what the composite morbidity outcome was included is the unplanned transfer to NICU, acute respiratory failure requiring intubation, postoperative need for non-invasive ventilation, and cardiac arrest. And when we look at this, you can see here, as your risk of S.A.R.V.A.C score increases, your risk of mortality increase. So if your S.A.R.V.A.C score is 10, your risk of mortality is, not mortality, I apologize, the risk of morbidity score is 42.7%. That means the risk of having any one or more of those events would be 42.7%. What are the factors included in the S.A.R.V.A.C score? Age less than 5 years. So when we talk about mortality, the age is less than 1. However, when we talk about morbidity, similarly to the apricot study, age less than 5 plays a role. Critically ill patients, a chronic condition indicator more or equal to 3. And what I mean by chronic condition is that if you have a chronic condition in one of those systems, are considered significant. Cardiovascular, congenital, digestive, endocrine, genetic, neoplastic, neurologic, respiratory, and urogenital. Or if your risk of the surgical procedure you're doing is 3 or 4. So you can see how you can add up the points. Just to clarify what's a chronic condition, this is a definition used by the Healthcare Cost and Utilization Project, and they define a chronic condition as any condition that lasts 12 months or longer, any congenital condition that is expected to last 12 months or longer, and any condition that places limitations on self-care, independent living, and requires ongoing intervention. To conclude here, I'm just going to give you a couple of examples. Risk of mortality, how do we calculate it? So if we have a 16-year-old intubated with pulmonary hypertension in the intensive care unit, coming for a Broviac or a PICC line for chemotherapy. This patient has a comorbidity of pulmonary hypertension. The patient is critically ill based on the definition of the PRAM because they're intubated and have mechanical ventilation. And the patient have a neoplasm, he's coming for chemotherapy. So the PRAM score is 9, which is a 17% of mortality. The 13-year-old previously healthy for arthroscopy, his PRAM is 0, his surgical procedures itself is 0, and your risk of mortality is 0. If we're going to look at morbidity in these patients, we're going to take an example of a 10-month-old Glenn, which is a cardiac procedure where your superior vena cava is connected to your right atria, coming for circumcision. The intrinsic surgical risk of this procedure is 1. The chronic condition that they have is cardiovascular. They have congenital heart disease. They're less than 5 years of age. So the risk is 5.2% of having the morbidity of being in the ICU after or requiring mechanical ventilation or arrest. A 13-year-old healthy for a spine fusion, they're healthy. However, the surgical risk of a spine procedure is 3. And so they are at the 5.2% of going to the ICU. And for those of you who do spine fusion, know that there is a risk of transfusion and potential post-op mechanical ventilation. So PRAM and intrinsic surgical risk are predictive of mortality, and we have shown that they are actually good predictors. The RAMPS, which is the risk of morbidity, is only one step toward understanding the risk of morbidity. There is much more work needed to be done in that realm, since the study that I mentioned is only at our institution, and checking if it's generalizable and applicable elsewhere would be important. We need to understand better the role of the provider, the impact of the institution, and the impact of our intraoperative anesthetic management on these outcomes. Thank you so much for listening and for the opportunity to speak to you today.